Statistics show that black women are 3 to 4 times more likely to die during childbirth than any other race. Joining us now to talk more about this is Dr. Veronica Gillispie-Bell. I want to make sure I get that in.
Thank you.
She is the medical director for the Perinatal Quality Collaborative. Good evening and thank you for joining us.
Thank you for having me.
We talked before and I was saying how this is such an important conversation to have. Before we even get into the questions we already had prepared, we were talking and you were saying that this is such an issue even before COVID.
Oh yes, absolutely. We talk about COVID-19 and it being a pandemic and it's a public health crisis, and that is true, it is. But so is maternal mortality, and so is the disparity of deaths that we see amongst black women nationally and here in Louisiana. That's a public health crisis as well.
Do you know why the rate is so high?
So there are so many factors that are contributing. My belief and looking at the data, implicit bias and structural racism are at the root. We know that even when we adjust for socioeconomic factors, looking at severe maternal morbidity, and morbidity is a precursor for mortality, that even when we adjust for socioeconomic factors, black women, especially a black woman with a college degree, is twice as likely to experience a severe maternal morbidity compared to a white woman with a high school education. Wow. So when we adjust for social determinants of health, which I'm not saying social determinants of health do factor into the outcomes, but even when we adjust for those social determinants of health, we still see a disparity in our outcomes. And so that points to the differences in how we deliver care. And those differences in how we deliver care are related to our implicit bias.
Right. And just for her background, she is a practicing OBGYN,
yes.
So she is really knowledgeable about this. So you're part of this collaborative.
Yes.
What does the collaborative do?
So the Perinatal Quality Collaborative partners with hospitals as well as patients, community advocates, working in our birthing facilities to make sure we are treating every patient every time, meaning we have readiness in place and we have response systems in place for the leading causes, the leading clinical causes of maternal mortality, and that's hemorrhage and hypertension. So we work as a collaborative with our birthing facilities so that we all learn from each other, and we use improvement science so that we're building quality capacity in these facilities so that they can start to make sure they have processes in place and structures in place to make sure we have better outcomes.
Yeah, and we definitely want those outcomes. You helped author the most recent report on maternity mortality. What did you find in this?
Yes, you know, it was really interesting. So in the previous mortality report that we published in 2018 that reviewed maternal deaths from 2011 to 2016, in that report, only pregnancy-related deaths were looked at. So those are deaths that are occurring because of something related to the pregnancy, okay? Also in that report, they only looked at maternal deaths up to 42 days after delivery. So in our report, we used a much more expanded definition of maternal mortality. So we looked at women that had deaths at the time of pregnancy up to 1 year after pregnancy. And we looked at all causes of death, so not just pregnancy related, but also pregnancy associated but not related, and then pregnancy associated but unable to determine relatedness. So because we had such a larger spectrum, we were able to look at those women that experienced mortality outside of just the clinical setting, and we actually found that homicide, motor vehicle crashes were also leading causes of maternal death.
Oh, well. Yeah, that would add to that. Well, something that just popped into my head, and we've seen disparities not only when it comes to race and everything, but also where you live. Could this also be pointed to where it's kind of like a urban rural situation?
So yes, so I think in a couple of ways. So when I talk about the social determinants of health, I always talk about them like a tree. And you can think about each of those social determinants of health as a branch off of the tree. But what I say, what matters is where your tree is planted. So yes, if you're in a rural area, then your access to health care is very different than someone that's in an urban area.
Right.
Economics is very different. So when we think about those factors and how those social determinants of health affect our health care outcomes, Absolutely, where you live matters. And there is data that shows nationally that the maternal mortality rate is higher in rural areas compared to urban areas. But even with that, we still see a disparity of Black women dying at a rate higher than white women. And I think it's really important to point out the urban versus rural area, because Louisiana is mostly a rural state by definition.
Right, definitely. So with this collaboration, you kind of pointed at it. What are hospitals doing to work with this and to help reverse this trend? Because we obviously want the numbers to go down.
Yeah, so the hospitals are doing a lot of work. Is what they're doing. So they decided to join this journey with us of trying to improve outcomes, and we actually are improving outcomes with severe maternal morbidity. So the way that we work with our hospitals, we generally have a kickoff learning session that's in person. This year it was virtually because of the pandemic. And so our hospital teams come and partner with us, and we, as a quality collaborative, the leadership, we introduce what our new initiative is going to be, what we're going to be focusing on. So our first initiative was focused on reducing maternal morbidity. The initiative that we have just launched is our Safe Births Initiative. And so that's focused on every patient, every time, having a safe, equitable, dignified birth. With that, focusing on respectful care, still focusing on hemorrhage and hypertension, but also looking now to lower our C-section rate. And so when we partner with our teams, we give them certain structure and process measures and outcome measures that we expect them to follow, because you have to look at the data. You don't know how you're doing without looking at the data. And so we give them different process measures that we expect them to follow, and we meet with them every probably 3 months through what we call our charter chats. Again, this is now done through Zoom instead of going to the hospital. And we go through what is their aim, what are they trying to work on to get to our collaborative aim, and then and as well as what are they working on for health equity and patient partnership. We always require them to have 2. And then we help them develop a 30, 60, 90-day plan that they can work on to get to their aim. And then throughout the time of us coming, the 3 months of coming to see them, we do monthly coaching calls and topic calls. And some of the coaching calls are things like, this is how you do quantification of blood loss during a delivery to know how much someone is losing, or up to, hey, this is what wellness looks like in COVID-19. Take care of yourselves as you're on the front line taking care of patients. And so we try to give them a lot of different tools, again, to help them build their quality capacity.
Right, it's a lot of work.
A lot of work.
Like you said, Dr. Veronica Gillispie-Bell, thank you so much for coming in, talking about this extremely important conversation that may have gotten on the back burner because of the pandemic, but our goal here is to bring it back to light.
Thank you so much for having me.